Good morning, everyone. Thank you so much for being here this morning, and thank you for making it an early morning. I'm Giovanna Imbesi. I'm the founder and executive director of LACNETS, and we're very thrilled to have the 2017 annual Los Angeles Neuroendocrine Tumor Patient Education Conference here at City of Hope, and I thank you all for coming. This has been about a year in planning. I want to thank City of Hope for this amazing venue and their beautiful campus. I specifically want to thank Dr. Leong, who planted the seed about a year ago. I think she's here somewhere. And to Crystal and Sarah, who have worked with us to make all of this possible. I also want to thank first Drs. Hendefar, Hecht, and Lee this morning. Some of you were in that session, sort of a Net 101, an open session we like to do every year where you can ask your questions and it's not videotaped. So thank you, doctors, for being here so early, even earlier than the rest of us. We really appreciate that. And I want to welcome all of our viewers online around the world. This is our first year live streaming, so hi to everyone who's tuning in from various parts around the globe. We thank our partners who have already been sharing on Twitter the live stream link, and look forward to having you join us for the day. So this is a little graphic of everyone who's here. And as you can see, some people traveled quite a distance from Alaska, Hawaii, the East Coast, and of course, mostly the Los Angeles area. And I think we have another map that's a zoom in. If we can switch to that one. Thank you. And this is a little more breakdown, so some people from the Bay Area, San Diego area. So the reach is Southern California and mostly the Los Angeles area, with a couple of outliers in Arizona. So thank you all for making the travel to be here. I also want to thank Lexicon Pharmaceuticals. They are our lead sponsor this year, and we'll be sponsoring some of the booths that you'll see in the exhibit room, along with our other sponsors, and are also sponsoring the live stream along with Novartis. They are a breakfast sponsor, so I hope you grab some good food already. And our other sponsors are Novartis, Ipsen, and Advanced Accelerator Applications, AAA. And we want to thank our partners this year. This is the first year that we are working in partnership with City of Hope, Cedars-Sinai, and UCLA, and NetRF, Net Research Foundation. As we'll all learn even more today, this is about partnership, and our theme this year is building resilience together. Resilience being the key word there, that many of us will find have been diagnosed years ago, and especially with new treatments. We've had a credible pace of new treatments the last few years. That resilience really becomes a key part of this. And the together part of it is what we learn from each other. There have been so many stories, including my own, about what happens at a conference and who you meet and how that changes your life. Maybe you'll meet a doctor today that will change your life. Maybe you'll meet another patient today who will share a story with you and help you manage through your own journey. So with all that housekeeping out of the way, one last person that I must give a special shout out to is Lindsay Judevine. Many of you have gotten emails from her, multiple emails. Where's Lindsay? There she is. So this could not happen without Lindsay's help. And I want to personally thank you, Lindsay, for all of your incredible organizational skills and just always bringing a smile. Thank you. So we'll start kind of at the beginning with the essential role of pathology. And for many of us, however we got to the point of a pathologist looking at our tissues, at that moment, that really determines so much of what's going to happen next. And I know we all have very varied stories of how long it took to get to that point and how many other things happened before we got to that point. But once it does get to the pathologist, and specifically a pathologist who is very, very familiar with neuroendocrine tumors, that really determines so much about the aggressiveness of the tumor. So we're very happy to have with us Dr. Deepti Dhall this morning. She is the Associate Professor of Pathology and Associate Director of Gastrointestinal and Liver Pathology at Cedars-Sinai. She has seen many neuroendocrine tumor slides in her work every day. So please welcome Dr. Deepti Dhall.
Good morning, everybody. I'm a GI pathologist at Cedars-Sinai, and one of my area of interest is neuroendocrine neoplasms. So today I'm going to discuss about the role of pathology in the diagnosis of neuroendocrine neoplasms. They are in the lower end of the spectrum is a well-differentiated neuroendocrine tumor, which is also known as carcinoid tumor. And on the other end of the spectrum is a poorly differentiated or a high-grade neuroendocrine carcinoma. This terminology was put forward by WHO in 2010, and before 2010, the terminology was very confusing. So even a well-differentiated neuroendocrine tumor metastatic to liver was called as well-differentiated neuroendocrine carcinoma. From 2010, the terminology is now clear. It's based on the histologic appearance, which I'm going to show you later. So today we are going to focus on well-differentiated neuroendocrine tumors, also known as NET. So they are very clinically and biologically heterogeneous tumors. One tumor may differ from another tumor, and for most part of it, they are considered malignant, except for very small tumors, which are called tumorlets. And their biology is very site-specific. So for example, ileal neuroendocrine tumors are aggressive tumors. They often present with metastasis. In comparison, rectal tumors, size for size, are less aggressive tumors. This is from the SEER database showing increasing incidence of neuroendocrine tumors. On the top is the small intestine. You can see from 1975 to 2005, it's rapidly increasing. And partly it's because of the increased surveillance and increased imaging modalities, which can pick these neuroendocrine tumors. Pathologic diagnosis involves a look of the specimen once it's removed, which is known as gross examination. After that, we do a microscopic examination. We call it histologic examination. And sometimes, or most of the times, we would do immunohistochemistry, which is an ancillary testing to confirm the diagnosis of neuroendocrine tumor. And fortunately, synaptophysin and chromogranin are pretty sensitive markers for neuroendocrine differentiation. This is an example of a gross examination of a specimen. This is an ileal resection. That's a small 1 centimeter tumor on the mucosal surface. These tumors are very distinctive grossly. They're very different from adenocarcinomas. Adenocarcinomas are usually large, bulky, mucosal-based masses, while neuroendocrine tumors are small tumors if you look at through endoscopic examination, and sometimes they can be missed. This is the cut section which only a pathologist can see because we cut them through the bowel. And if you can see, on the top is the mucosal surface. So, if patients undergo colonoscopy, this tumor may be easily missed because they only see the mucosal aspect of it. But here you can look on the tumor is all invading into the bowel wall and into the fat. This is another example of an ileal neuroendocrine tumor, which often present with metastatic disease. This is a lymph node involved by the tumor, and we can see a small primary tumor right there. And again, this is a very classic gross look of a neuroendocrine tumor. There are 10 yellow tumors, and they are submucosal tumors. These are some examples of pancreatic NETs. Here you can see a large multinodular mass almost replacing the pancreas. In this one, it's a hemorrhagic tumor located close to the splenic vessels requiring splenectomy. This one is close to the pancreatic duct requiring pancreatic resection rather than enucleation. And this is a Whipple specimen where there's a small, well-circumscribed tan appearing neuroendocrine tumor. This appearance is also very classical for pancreatic NET in comparison to adenocarcinoma, which are very ill-defined and they look very different. This is the histology of neuroendocrine tumors. We look at through microscope, and neuroendocrine tumors are very classic. I can train any person here. All the tumor cells are arranged in tight nest. You can see here, again, this is the mucosal surface. They are submucosal tumors, and this is a high-power view showing uniform tumor cells. They have this abundant pink cytoplasm. The blue are nuclei, which are small and round. One nucleus resembles the other nucleus, and the nuclear chromatin, the material within the nucleus, is very fine, and we also described as a salt and pepper-like nuclear chromatin. This is a very characteristic histologic appearance and often does not need immunostaining for confirmation. This is just an example of those two stains I talked about, chromogranin and synaptophysin. This is immunohistochemistry. The tumor cells stain brown with these markers. So after making the diagnosis of neuroendocrine tumors, we report following parameters such as tumor site. We talk about grade and stage of the tumors. And there are other histologic parameters such as tumor in lymphatic vessels or in blood vessels, which is a bad prognostic marker, perineural invasion. And for certain tumors, as I said, the biology of these tumors are site-specific. So for example, stomach NETs, it needs further histologic subtyping, which I'm going to talk later. And finally, we report about the resection margin, which basically ensures complete excision of the tumor. So grading and staging is the key for any tumor. Grading assesses the proliferative activity of the tumor. It's based on mitosis. Mitosis is the process where one cell divides to form two cells. And Ki-67 proliferative index also identifies proliferating cells, a larger proportion of proliferating cells. So it's much more sensitive than mitosis. Mitosis is seen on H&E examination. H&E is the stain we do for microscopic examination, while Ki-67 is an immunostain, the brown stain I showed you. And the staging system is based on the tumor site, the tumor size, and the extent of invasion, including regional metastasis or distant metastasis. When we stage, we report in the form of PTNM staging, which is an American Joint Cancer Committee staging system, where P stands for pathologic, T stands for primary tumor characteristics, N for nodal disease, M for distant metastasis. Next year, from Jan, this staging is going to change. It will be a 8th edition, so there will be subtle differences in the staging reporting. This is the current grading system. We divide, let me tell you here, this grading system is for gastroenteropancreatic neuroendocrine tumors. The grading is a little different for lung, which I will talk about it later. But mostly the tumors are divided into G1, which is a low grade, G2 intermediate grade, and G3 is high grade. Fortunately, G3 tumors are rare, and the G1 and G2 tumors are well-differentiated tumors, and here we can see how they are cut off, how they are divided based on mitosis and Ki-67 proliferative index. These two survival curves are just highlighting the importance of grading neuroendocrine neoplasms. This is a metastatic neuroendocrine neoplasm where we can see the lower grade ones, they do better than high grade tumors. And this was a study done at Cedars where we see the lower Ki-67 tumors do much better with progression-free survival than high grade NETs. This is an example of a grade 1 NET with very few Ki-67 labeled cells, so this is a grade 1 tumor. Here you can see around 10% of tumor cells positive. I remember there was a question among the audience, how do we count this? We basically take a picture of one slide and we count every cell, every negative cell and every positive cell, and we have to count for approximately 500 to 2,000 cells to give a number. And Ki-67 varies from one area to the other tumor. So we first look at H&E, we figure out which is the most proliferative area of the tumor. We do Ki-67 on one slide, and then we count it by either by digital or by counting. And there are a lot of studies which proves that the manual counting is the best way to give a number. This is a grade 3 tumor. You can see a lot more Ki-67 proliferative cells here in the slide. And sometimes this is an example where there's a low-grade tumor here and suddenly there's a high-grade transformation with a lot of proliferating cells. This is another example of a G3 tumor with a lot of proliferating cells. But again, look at the histology. This is a well-differentiated neuroendocrine tumor with a high proliferative index. This is just an example of a high-grade neuroendocrine carcinoma. They also are very highly proliferative, but the histology is very different. They look very highly malignant, lots of areas of necrosis, and they're very different histologically. The problem with WHO 2010 classification is that both well-differentiated G3 tumors and poorly differentiated G3 tumors were lumped together. As you can see here, they look pretty different on left-hand side. So in 2017, this grading is going to change and G3 tumors will be divided in G3 well-differentiated and G3 poorly differentiated. So the picture which looks different with a very well-differentiated appearance would be called well-differentiated G3, and the lower one would be called poorly differentiated G3. And sometimes this can be very difficult. So there is a way to differentiate between the two, and we often need a clinical correlation, molecular correlation, and imaging correlation to figure out between the two. Just an example of a gastric NET, they are divided into 3 different types. This is really important prognostically. So we do that in pathology. This is an example of a type 1 where the tumors are multiple, but they are very indolent and they do not metastasize. In lung, the classification is a little different. It's still divided into well-differentiated, poorly differentiated, and well-diff is G1 are called typical carcinoids, G2 are called atypical carcinoids. The only difference is they incorporate necrosis, which is a cell death, into account, and Ki-67 proliferation is not a grading criteria. And yes, NETs and liver are often metastatic, they are not primary, and there is a way to figure these out. It's a little complicated here, but first, if we see a tumor, if there are neuroendocrine features, we confirm it by a neuroendocrine markers. Once we know it's a neuroendocrine neoplasm, we figure out whether it's a well-differentiated neuroendocrine tumor, and we separate from poorly differentiated neuroendocrine tumors. Once we know it's a well-differentiated neuroendocrine tumor, and the primary site is unclear clinically, we have several immunohistochemical stains to figure out where the primary site is. Some of them are really good. Once we figure out where the site of origin tumor is, then we can, based on mitotic count and necrosis, we can grade these tumors further in lung and in GI and GI tract as follows. Thank you.